Sowmya Peri. She's talking about furrowing deep the rodent way, a clinical approach to a case of atypical Murren's ulcer. So I think after your time is up, the slides stop showing because I saw a lot of speakers continue speaking. After that, they don't know that the audience is not seeing the slides. So please keep that in mind. Once your time is up, you can stop.
Sure. Good morning. So I present a case of a 65-year-old male who presented with redness, pain in the right eye since 3 months with episodes of remissions and exacerbations. He had no history of any systemic illness and best corrected visual acuity of 6/12. On slit lamp examination, as we can see, a crescentric shaped ulcer in the inferior peripheral cornea with undermined central edge at the ulcer base and 90% thinning was noted. No evidence of scleritis was seen. Anterior staphyloma with 360-degree vascularization may be due to past history of trauma as told by the patient was noted in the left eye. All the investigations that were done were negative for the patient. So a provisional diagnosis of Murren's ulcer was made in the absence of scleritis, in the absence of any other systemic associations to the patient. So the patient was started on topical steroids, lubricants, and oral doxycycline. So the inferior crescentic shaped ulcer showed signs of healing with conjunctivalization of the inferior cornea. And the patient was lost to follow-up after 6 months. So when he presented again after 6 months to us, he was using topical steroids without tapering. So on slit lamp examination, a crescentric shaped ulcer in the inferior peripheral cornea with 90% thinning with perforation, which was Siedel's positive, was noted this time with best corrected visual acuity of 6/36. So steroids were withheld temporarily in view of perforation, which was noted probably due to chronic use of steroids, and antibiotics, lubricants, and oral doxycycline were given. Conjunctival resection was done. BCL and glue were applied at the perforation site. So on restarting the topical steroids, there was progression again with inferior active thinning from 3 to 9 o'clock position and plugging of the iris inferiorly. Hence, again, we stopped the topical steroids. So this time we continue with oral steroid 60 mg in tapering doses along with oral doxycycline along with the other conventional medical management that we had started. Inferior patch grafting was done for the patient after 2 weeks as the inferior crescentric ulcer had no signs of healing and the vision of the patient was counting fingers 1 meter now. So post patch graft, the patient was continued on topical and oral steroids along with the other line of management. So at 3 weeks post-op, graft melt with peripheral vascularization was noted. Hence tablet cyclosporin 50 mg twice a day after physician clearance was started along with the existing medical management. So in the last follow-up, circumferential healing with peripheral vascularization and central spreading with active central margin was noted as seen in the last picture in the last follow-up. So despite best of a medical and surgical management, whatever we could give in our institute, the vision was hand movements PLPR. So why this case? We present a case of atypical malignant bilateral progressive form of Murren's ulcer in a 65-year-old man, which is painless and aggressive since its presentation, which is usually seen in younger patients. Perforation of Murren's ulcer, which is also seen in younger patients, was noted on chronic use of topical steroids. The patient was refractive to all other available therapies, and this resulted in severe visual morbidity of the patient. The patient and attenders were resistant to be referred to a higher center. So thank you. So I would like to know how else could we have managed this case in a better way so that we could salvage the eye. Any suggestions, please let us know. Thank you.
Did you start the patient on cyclophosphamide or was it only the oral steroids?
Cyclosporin only, ma'am. First we started with topical steroids, but repeated perforations were happening. So we went for oral steroids and then we went for cyclosporin, ma'am.
Oral. You went for
oral, ma'am.
I think pretty much managed it.
I think the main thing was that the patient presented, it was more than 2 quadrant of involvement. And you did workup and then you started topical steroid, patient went back. So basically this disease is a disease of exclusion and this is an autoimmune disease. So it needs systemic immunization on the day 1. You have Murren ulcer present, your OPD day 1, give IVMP 3 doses, do the conjunctival resection same day with TABCL, otherwise it will go and perforate. And this topical steroid will not take care of this thing. So there is a step ladder approach. You start with oral steroids, go to immunosuppression, you start with cyclosporin, then you go to azathioprine, mycophenolate, cyclophosphamide, biological inhibitor. So topical steroids will not take care of Muran ulcer. Okay.
I agree.
Yeah.
Like if it's bilateral atypical, it's very aggressive. It's known to be aggressive. So even your management has to be aggressive.
Actually,
Yeah.
the patient presented to us, the other eye was anterior staphylomatous. So he was giving a past history of trauma. But trauma is also one of the causes of Muran's ulcer. So we don't know if it was unilateral or it was bilateral. Basically, unilateral aggressive is more seen in elderly males. But this case is a bilateral aggressive Muran's ulcer, which is normally seen in younger patients, but we see in a 65-year-old man.
So it's a great case for learning. So if you see such a patient where already there's a staphyloma, I think you should keep it in mind that it is a bilateral disease.